Okay, well, good morning, good afternoon, good evening to the IHF members joining us for today's webinar, brought to you by the IHF Virtual Care Special Interest Group in partnership with Apollo Hospitals Group India. I'm calling in from the beautiful Scottish Highlands and looking forward to hearing from our expert panelists today. The session will be recorded and we will be sharing that with the IHF membership for those who couldn't attend in person. I think we're expecting a few more participants to attend, so give them a few moments to join. Just a few housekeeping rules. If we could please keep everyone's mics on mute, and then share any comments, thoughts, or questions in the chat box. We'll hopefully have some time for some Q&A to all panelists at the end of the session. So we all know that virtual care is often proposed as one way in which hospitals can reduce their carbon emissions. But how can we get the evidence to show that this is actually the case? And what do hospital leaders need to consider when they're thinking of virtual care programs from a sustainability perspective? Today, we'll be hearing from our panel of experts on this topic in a discussion which will be expertly chaired by Dr. Karan Thakur, who's Group Vice President for Corporate Affairs and Sustainability at Apollo Hospitals Group India. And I'm also very happy to welcome our speakers, Rachel Desane, who is Director for Sustainability Measurement and Impact at Health Direct Australia, and Becky Housley, David Cruttenden Wood, and Kate Townsend, who are a team from the NHS Hospital Trust in Hampshire, who will be sharing their experiences of virtual wards and environmental sustainability. We're also joined by Dr. Sai Praveen Haranath, who leads our virtual care special interest group at the IHF, and he'll be sharing some of his experiences as a virtual care provider. And Dr. Sai is with us also today. So I'll hand over to Dr. Karan to kick us off with this session. Thank you.
Thank you. Thank you, Ilona, and thank you to IHF for having us here today. A warm welcome to all the participants and especially the speakers for taking time out and really share some experiences around virtual care and its impact specifically for decarbonization and driving sustainability into our health systems. As Ilona mentioned, virtual care is being increasingly both enhanced but also integrated into the healthcare delivery system. And it's important driver of access, but also keenly studied for the impact that it could have, the positive impact that it could have on sustainability and building sustainable health systems. So before I really hand it over to our experts to speak about this subject, I just wanted to frame this conversation around a few vectors for consideration. And as Ilona mentioned, please feel free to put your questions, any comments on the chat box, and we'll be very happy to point them towards our expert speakers closer to the end of today's session. So the first important aspect for a lot of you would be aware, but for those who are not, the health system has a large carbon footprint itself. It is estimated that this is close to about 4% of global emissions. And when you look at global emissions per sector or industry, we are actually higher than shipping. And that just gives us the scale of the emissions that are being emitted. And of course, it is higher in certain regions of the world, but as the health sector grows, these emissions are expected to increase over time. So that is the central issue of carbon emissions and the related impacts that it has, not just on health delivery, but also on the environment, ecology, and the climate crisis that is currently ensuing. The second important consideration is that we're all operating in a health system that is currently inadequate in terms of resourcing and availability of health services. And this is not just an issue of the global south, but is actually an issue globally from advanced health systems to those in mid-maturity to others that may be more bare bone. And as we grow, as health systems grow, I can give an example of India, where we need to create 1 million beds over the next 2 to 3 decades in order to have a good bed to patient ratio, or at least improve access. And we don't really have the carbon headroom, as it were, to grow without growing green. So that's the second important aspect, that if we really want to make healthcare accessible, we can't afford to do that how we've done it in the past. The third is really, and this is quite self-evident, the impact of the climate crisis on human health and health systems. We know that there is no organ system or condition that is not impacted, made worse, or is a causation directly through the impact of climate change, whether it is poor air quality, whether it is vector ecology that is changing, or the heat waves that are becoming rampant across the world, and don't remain an issue of certain geographies. Along with that, we also know that when we look at human health, we really need to see it through what the WHO calls the One Health approach, the lens that planetary health, human health, and animal health are all interrelated. And this is something that really stood out in sharp contrast during the pandemic, where the interface between animal health and human health showed the impacts that this could have. Fourth is resilience, and resilience more broadly. We live in a very volatile world. We don't need any further examples of that than the times that we live in. There is the impact of geopolitics. There is supply chain constraints. There are resource constraints that we have on our health systems because of what is happening across the world. There are climate shocks that continue despite a lot of effort being taken in terms of decarbonization. And of course, the specter of pandemics, epidemics continues to hover over most health systems. And while we hope that the next one does not strike anytime soon, but we know the changing nature of disease means that at some stage, the health system and humanity will probably have to come to face with pandemic. So those are some of the more systemic shocks in which we operate. And lastly, priorities for health systems is also fast changing. There are concerns about growth of the economy, and if there is not adequate growth, are there going to be enough budgetary resources being made available for health systems to adequately provide services and resources for citizens and patients? There is a funding and financing gap that one is witnessing. Health budgets are actually shrinking in many countries and economies, and we've seen the overseas development assistance, the ODA, really evaporate or downsize over the past 2 years. And this was critical in providing critical support to fragile health systems to ensure that there is continuity of services. And the focus on prevention is another priority area. We cannot just be in curative care. And how do we do that when we look at the access paradigm? When we look at sustainability, traditionally it has been looked at through three lenses of solutions, whether it is the solutions that will help mitigate our carbon footprint, help us adapt both as health systems and human beings towards the climate crisis, and really building resilience to all the shocks that I spoke about earlier. But when we look at virtual care, we really need to also probably rethink this triad in terms of access and how we improve that through virtual care, looking at decarbonization, really reducing our carbon footprint and mitigating some of the impacts that the health system creates. And lastly, resilience building. How is it that even if physical shocks make sure that the access to a facility in the physical mode is not possible, can virtual care really help us bridge that divide? But within virtual care, there are a whole gamut of issues, whether it is decarbonization, skilling of the healthcare workforce to adequately take over, delivery of care virtually, looking at data security and patient safety and outcomes. How do we really measure those? How do we look at equity? Again, is this going to become of the haves and have-nots? Parts of the world that don't have data or access to, fast internet, are they going to be left behind in the future health system that we create, which is more virtually attuned? And of course, the carbon footprint of the delivery of care virtually itself is an area of growing concern. So a whole host of issues. We don't expect to address them all in 75 minutes, as much as one wish that we could, but the experts here would really lay emphasis on some of those solutions and rather than reiterate the problem at hand, look at what those models could look like in terms of measuring and decarbonizing, and also models of delivery of care. And then later we'll discuss some of those issues that are highlighted in these presentations through your questions and also spotlight. So without further ado, let me hand it over to Rachel, and really ask her to talk us through issues of mitigation and adaptation in terms of a strategic approach, and what are some of the models that can really help us get there. Rachel, I'll pass the mic to you, and the stage is yours.
Brilliant. Thank you so much for the introduction and the opportunity to be here. It's really great. And for you all who are attending, thanks for taking the time to be here. As Rachel was saying, I work for a company called Health Direct, and we are the national provider of virtual care services in Australia. We are owned and funded by the federal, state and territory governments. We provide a whole range of virtual health services 24 hours a day through our websites, symptom checkers, nurse triage, as well as access to virtual clinical consultations. So in addition to those sort of direct to consumer or patient services, we also provide hospitals and health providers with a video call platform so they can then offer their own virtual care services, be it outpatients, virtual ED, triage, aged care, even allied health and rehab too. So over the 20 years that we've been in operation, we've demonstrated the economic and social benefits of virtual access to care. But more recently, particularly with the climate crisis, we've started to ask, how can we also measure and report on the environmental aspects of this work? And this aligns to my second job. I do a PhD at the moment alongside my day job, which is to try and develop a triple bottom line evaluation framework for virtual care to enable decision makers to consider people, planet and prosperity when they're looking at investing in virtual care. Because for me, you shouldn't be making decisions unless you've got a seat for all three of those at the table. So like many of you, I'm sure, climate change has become one of our biggest priorities to look at, not only as we're seeing more climate-related demand for care in heat waves, bushfires, floods and storms, but our shareholders are wanting to understand how can virtual services help or hinder their climate resilience efforts, be it in adaptation, so ensuring we can continue to allow for access to care when mobility or other things limit that, and also in mitigation. And that's really what I want to focus on in this discussion now. How can we actually demonstrate and measure what virtual care can do to support the health sector reduce its emissions? A couple of years ago, I did this piece of work for the Australian government to estimate the health and aged care sector's footprint or emissions. And we can see here that patient travel is about 10% of that total footprint. So there's a real sizable opportunity for the health sector to show that virtual care is part of that broader strategy to demonstrate how it's contributing to those net zero commitments. Because across Australia, whether it's within an organisation or at a local, state or national federal government level, we see regulations, policy and commitments being made to achieve net zero, or at least to reduce emissions. And in some particular areas, they actually have health sector specific targets and requirements coming in. But how do you measure and report on the emissions of avoided virtual care? Well, the methods for measuring emissions have been around for quite a long time, whether it's for a particular product, a service, an organisation, or even a country. And they're namely split into these two things. One's called an emission factor. Those are the estimate of the emissions associated with a unit of something. So think of like a kilogram of steel or a litre of petrol. And they're typically printed by your government. You see here the Australian National Greenhouse Accounts Factors. That's like a book, a list of all of the factors. Or sometimes you'll get them provided by a vendor in a product disclosure statement or a reporting tool. For example, AWS provides the emissions associated with their data through an online carbon calculator tool. And then you have the other one, which is emission intensities. They are estimates of emissions per dollar value of expenditure. So 100 kilograms of carbon for every $1,000 spent on lawyers, for example. So by their nature, they're a lot less accurate. However, what you'll see is that most inventories, be they organisation or country, end up using a hybrid mix of both. And while we've created that national footprint, and there've been some great studies published providing emission factors for things like pathology tests or emission intensities for surgeries. As an example from actually my old professor at Sydney Uni for a cardiac surgery, we don't have any actual published factors or intensities for standard health consultations, be they virtual or in person. So we can't see what the potential avoidance of transitioning to virtual care is for that huge component of the health sector's activities, the delivery of consultations. And that was really the big driver for the development of the work we started a few years ago to develop this national virtual health emission measurement framework. So like all good work, we started by reviewing the literature. We found a massive variation in what was reported about the savings, ranging from 1 kilo of carbon per consultation to almost 400. And that's namely due to transport methods. It's obviously a lot more emissions to have to fly across Australia to see a cardiologist versus walking around the corner to see your local doctor. But what we did see was consistently 3 areas of emissions associated with how to calculate virtual health emissions. They are transport, supplies, and virtual call emissions. But each one of these needs its own calculation and data inputs, and they're quite varied. So here's the first one. Travel and transport are by far and away the major contributor and probably the most complex in terms of the variation in data. Now, it's a stepped process. So the first thing you need to ask yourself is, what's the likelihood of an alternate transport? What we mean by that is, would the person have taken public or active transport, like walking or cycling? Then if they did drive, was it with a combustion engine, so creating emissions, or perhaps an electric vehicle? Then we look at how far they drove to the clinic and back, or the point of care, and then the emissions associated with the type of vehicle. And those transport emissions are typically in those books like the National Greenhouse Accounts Factors, or sometimes you can find them in environmental management systems too. The next area is about supplies. So we worked very, very closely with our clinical team, as well as looking at published studies. And working backwards, you start by saying, what are the typical types of consumables, diagnostic procedures, or interventions that are likely in this type of consultation? So gloves, gowns, FBC paths, CT scan, that type of thing. How many of them would typically be used in an ED presentation or a kidney outpatient? And then we also looked at the rate of avoidable or overuse. There's really fantastic resources through something called Choosing Wisely, and you probably have your own local flavour of that too. And then finally, super, super important is that you must deduct the actual costs of the delivery of the virtual call. Cloud services and virtual may seem sort of, invisible, but there's very real energy, water, materials required to operate the data centers. And this is increasing as AI gets sort of baked into most health IT services. So we took our figures directly from published literature. This comes from Thiel and gives us the per minute estimate of video or audio calls. Great. So now we had those calculations, we needed to try and apply it to our service. But as you'll see here, we received over 4 million calls from every part of Australia and for many different types of services and needs. And it would be extremely time consuming and labour intensive, in addition to potential data privacy issues, if we tried to calculate that for every single call individually. So we had to find a balanced, easy and repeatable approach that would still be fair and reasonable. And most of all, we wanted to build it in a modular fashion so others could use it and we could use it in the future to be a strong baseline in comparison. So the first thing we did was we looked at our services. We picked the types of consultation you see here. Ambulance is people coming by ambulance to the ED. ED is self-presentation. And then created specific calculations for each type. So, and they're based on those transport, supply, and digital emissions there. Now, we then had to figure out all of the inputs, and the major one being travel distance. Now, one study that I saw in Spain used just one national emission factor for a health consultation. I think it was 5 kilograms of CO2 for every in-person GP visit. But as you can see, and maybe you've been here, Australia is very big, and we have a very large variation in how people access care, how care is delivered. So one average travel distance number wouldn't really work. Postcodes also wouldn't work for us. You see here 0872 is actually almost 5 times larger than the entire UK by land area. So we chose to use a geographic subzone based on regionality and remoteness. It's specific to Australia, called the modified Monash, and splits things out by regional areas. So gathered all the data, the necessary inputs, and crunched those numbers, and then published this report for all health organisations in Australia to use that provides that estimated emissions associated with each type of consultation. You see New South Wales listed here. So you can use those in a single clinical pathway. Let's say your hospital wants to measure the emissions of transitioning 5,000 cardiology outpatients to virtual delivery. So if a in-person one is 5.97 kilos, I then have to account for the delivery of the virtual call to get my net, times that by the 5,000 consultations, and can see that this program contributed a saving of just under 30 tonnes of CO2. You can also use the emission factors for more complex pathways if, like us at Health Direct, you provide multimodal services. So that's where things like virtual front door, triage, virtual ED, the original intent of the patient could be varied. It might be do nothing, it might be call an ambulance. And then the end point after the triage could be a number of things too. It could still be to call an ambulance. So let's dig into that one as a use case to show you how that could work. So meet Meti. They're implementing a new virtual ED program. They want to understand the emissions impact of this as part of putting forward a business case for future funding. The first thing they do is start looking at pre-intervention, so creating that baseline. How many ED presentations and what mode of transport, ambulance or self-presentation? Where did the people travel from? So you see those modified Monash zones on the top there, and that gives us our volume input. Then we look up the relevant emission factors for that region and calculate the baseline, which in this case, 2.5 kilotons. Then what you do is say, okay, what will my new model of care be? So I see I've still got ambulance, still got self-presentation by ED, but I've now got an audio virtual consultation and an urgent care clinic. Maybe there's a triage where we can send people to the local urgent care clinic that is often a shorter travel distance than hospital, certainly as in Australia. And what that does is give you a new baseline of 2 kilotons, and you can see you've saved 457 tons of carbon. And look, we did this on sort of 5 quite standard pathways, but it is modular, so you could adjust it. Let's say you've got a very specific patient cohort like lung cancer patients. Your model of care is that patients would travel to the hospital 1 week prior to the appointment to have path and scans, and then travel back a week later for the consultation. You're putting forward a business case for a new virtual pathway that has a different mix. And what you do is map out each of the steps in those pathways to look at what the adjustment of inputs are. This table might make it a little clearer for you. So the in-person one, you see the travel, 2 hospital visits, you see the supplies that are used, nothing for the virtual call. You then see it for virtual path and there, use the volume numbers and create that estimated avoidance. So for those of you in organisations that conduct climate-related financial disclosures or report organisational emissions, you can also potentially use these figures. We have seen one hospital here do that, where you use the travel distances for patient and visitor transport and employee commuting too. The building blocks are sort of all there to do that. So how do you get started? Well, first thing to do, have a look at your service and decide on the health consultation types. Then think about the geographic category you want to use. It could be mesh blocks, SA2s, and then work out the comparative pathways. So understand what those different travel, supply, and digital or virtual inputs are. For travel distance, you could review patient records, do surveys, and create that population-weighted average distance. We got a lot of great information from public sources here in Australia. We have the Bureau of Infrastructure, Transport Research Economics that publishes a lot of this to give you the rates of public transport and electric vehicle use. Work with your clinical teams to determine what typical consumables and diagnostics would be used. Have a look at the typical lengths of your calls, and do be aware that we are going to be seeing a lot higher rates of energy and emissions associated with delivery of virtual because of AI. It's still a lot less than petrol and transport, but it is something I think we should be transparent and honest about. Then start with one patient cohort, use it, demonstrate it, and then, get out there, publish, share, educate, advocate in your business about this, because it's up to all of us, I think, to normalize including environmental costs and benefits in our business documents. I think that's where you get that cultural change, when it just starts becoming normal. So I'll stop there. Thank you so much, and hand on to the next speakers, I think.
Thank you, Rachel. Thank you for that. And also thank you for outlining very clearly where one could. Rachel, thank you for that. And also thank you for outlining very clearly where one could exercise that you covered at the end of your presentation, but also very indicative of the spread that you could do with this model, where it could be a generic consultation, or you could look at a care pathway for very specific patients, and then do a comparative in terms of what the benefits are. And like you rightly pointed out, while there could be benefits that we see in terms of avoided emissions, but there could be a negative externality in terms of the carbon footprint of storage and of data centers that are increasingly now becoming resource intensive with the advent of AI integration into these solutions. So thank you for that, and thank you for also giving us some of the scientific approaches that one could take as we begin this journey on really measuring what the impacts we are having as part of our care delivery. So thank you, Rachel, and I'm sure there'll be a lot of questions. I certainly have a few. I'll come back to you once we are done with our next set of speakers. And I'd like to hand it over to Kate, Becky, and David from the Hampshire NHS Trust to really showcase some use cases and case studies very specifically in terms of virtual ward pathways. So Kate, over to you.
Thanks, everyone, and thank you for having us. And thank you for having us, and thank you, Rachel. That was a really interesting presentation you've just done for us, and I think it will flow quite nicely into what we're discussing today. So my name is Kate Townsend. I'm the Sustainability Manager. I'm currently working for Berkshire Healthcare Foundation Trust, but when I was doing this project, I was working for NHS England. And I'm here today with a couple of colleagues. Becky, do you want to introduce yourself?
Yeah, hi. So I'm Becky Housley. I am the consultant nurse, and I oversee all of our virtual health hub services at Hampshire Hospital, and the virtual wards is one part of those services. So lovely to meet you all.
Thanks. And David?
Hi, morning from sunny south of England. My name is David Quentin-Wood. I'm a general colorectal surgeon, but I'm also the clinical director for virtual healthcare for our trust down in south of the NHS. So good to meet you.
Thanks. And so today we're discussing a paper that was written between myself, David, and Becky, and a few more of the virtual wards teams on exploring the carbon impact of virtual wards. So digitally enabled care, as we've sort of heard about today, has really emerged as a promising alternative to traditional inpatient bed days. And this particularly happened during the pandemic, when it was safer to treat people out of hospital. So one of the positives really is that COVID has massively changed the way that we work as a healthcare system, with technological advancements enabling remote care to take place. Furthermore, positive patient benefits have emerged from treating patients within the comfort of their own home. So that social impact of being near loved ones, excuse me, and being more autonomous in your own care has had really positive health and social outcomes for patients. And also there's also been positive financial implications as well for this kind of care. what was never really considered at the design phase of virtual wards or properly sort of evaluated afterwards in many cases was the environmental impact. So similar to what Rachel was just saying, that triple bottom line analysis of cost, care and carbon, we're missing that carbon element quite a bit. And we know that acute hospitals are particularly intensive environments, energy intensive environments. They require a lot of staff to run sort of very large building sites 24 hours a day. Whereas treating people remotely can replicate that hospital level care in much lower intensive environments. When I was in NHS England, what we saw was a real variety of virtual wards being rolled out, which was quite rightly dependent on the local population. Some models had really high rates of travel with multiple clinicians all travelling separately to a patient's house multiple times a day, whilst others, similar to Hampshire hospitals, were predominantly remote care. So NHS England created a national toolkit, which sounds not too dissimilar from what Rachel was just describing, which helped us to calculate the carbon emissions of virtual wards. And so Hampshire hospitals became the first to sort of officially utilise this toolkit, and we were the first to publish our findings that you can see snippets of on the screen there. And so today's presentation will go through the key findings and highlights of this paper. Oh, I can't. There we go. So to give you some national context about sort of greener NHS in England, the UK, so the NHS in England contributes about 4 or 5% of the UK's carbon emissions, so similar to that global figure. And we're by far the highest in the public sector. We represent about 40% of all public sector emissions. So back in 2020, we were the first National Health Service to make a pledge to go net zero for all our direct emissions by 2040 and all our indirect emissions by 2045. And since then, over 20 other countries have followed suit. We're also the first National Health Service to put this pledge into legislation within the Health and Care Act 2022, in recognition that we're really negatively impacting our population health by contributing so many of those carbon emissions. So the pie chart on the screen that you can see there is from our updated 5-year progress report, where the methodology is internationally recognised for the sophistication of carbon calculating for a National Health Service. Over to you, Becky.
Thank you. So the virtual wards at Hampshire Hospital all really took off during the height of COVID to support respiratory patients, and all of our virtual wards that we have now are for acutely unwell patients that would otherwise be in hospital. We now manage about 10 different speciality virtual wards, ranging from surgery, respiratory and frailty, to name a few. We have 120 live patients at any one time, so it's a really busy service. Most of our consultations, as Kate explained, are remote and they're managed over the phone. But we can also support with face-to-face visits, and we link in with our community teams when needed if we're worried about a patient that needs to potentially be admitted. So most of our patients are early supported discharges from hospital, and we are very heavily reliant on the hospital clinicians to refer us patients internally. We also support with admission avoidance work. Part of our service also supports the single point of access. So my team also manages all the direct admissions coming into the hospital from our community colleagues, whether that's GPs or community staff. So we therefore have the opportunity to be able to directly admit onto our virtual wards when we have those calls coming through our hospital, and we can therefore support with many admission avoidance patients as well. Next slide, please, Kate.
Thanks. So Hampshire Hospitals and NHS England, we set out to find out the following objectives. We really ultimately wanted to understand the carbon footprint of a virtual ward pathway, and what we did was we mapped out all the carbon activity points that a patient would go through in a typical journey. The second objective was to establish avoided carbon emissions. So utilising previous research from the Trust, we were able to calculate the avoided carbon emissions through avoided bed days, or bed days saved, as we've sort of framed it. And we were able to then really do a good comparison of what that journey looked like, what the carbon footprint was of a journey in a virtual wards versus what that journey would have looked like had they been in a traditional inpatient bed day. So really seeing that comparison. And then finally, we also looked at the possibility of being able to do this process using the data that was already collected in healthcare versus manually calculating all those carbon activity points, individually, manually sifting through patient records to see the methodological differences in that. So David's going to share more on the study and the findings.
Thanks, Kate. So just want to point out, if anyone wants a copy of the link to the paper we published in the British Medical Journal, we're happy to send that to you. And what Kate was saying is could we actually successfully clinically quantify the carbon impact of a patient journey through virtual wards, the hospital home pathway, using the toolkits that's out there and other national carbon output measures? And then actually, would this demonstrate a significant lowering of the carbon cost to an inpatient hospital stay? And then in the real world, where people have a mixture of virtual and real face-to-face care, could we actually quantify the prevented carbon emissions using bed day analysis when they've been avoided to see the tangible benefits, if any, of virtual care hospital at home pathways? So we performed a retrospective cohort analysis of our two busiest wards over 1 year, which were our acute respiratory patients and our frailty virtual ward patients, which was about 42 and 58% respectively. That contained 1,260 patients' carbon journey. And what we did, we drilled down and looked at all their touch points, calculating their carbon footprint, how far they travelled. And Rachel, if you're still there with the generator kicking in, no one travelled by a fixed wing plane or helicopter, unfortunately. But on the Isle of Wight, that might happen, which isn't too far down south. And then we also did a smaller cohort, deep dive, looking for concordance, correlation, and accuracy as well. So these are the high-level findings on the slide. And what we actually found as a takeaway home is that if you're on a virtual ward, the patients used 4 times less carbon emissions. So that was actually showing that the average virtual ward patient uses 8.4 kilograms of CO2e compared to 37.9 if they're an inpatient. That is statistically highly significant with a p-value of 0.019. But what is important to note here, and this is the real world stuff, is that even when patients have blended care, so they maybe come in, stay in hospital for a night or sent home, it really does show an improvement in a significantly lower carbon footprint. So the take-home message, even small amounts of virtual care, if you're a jobbing clinician, is important as well, worth the effort. So next slide, please. So this is quite a busy slide, but it talks to the point that this is actually quite a complicated analysis, and you can see what Rachel was also talking about. There is a commonality in theme of how we go through things, and I think both of our talks really do complement each other quite well. So this demonstrates the real world saving of patients receiving virtual care of a hospital home pathway. So as you can see, we need to divide patients into how the care was actually delivered. Was it solely remote? Was it blended? Or was it a mixture of early supported discharge, getting people out of hospital earlier? Remembering these are sick patients, we're taking risk getting these patients home. So is it worth getting them home early? Because we might be expending more money on single-use plastics and things like that, more carbon and single-use plastics in the community. So we needed to know that. So from understanding their different journeys, we could quantify the gross carbon saving from delivering care out of the hospital. We needed to then offset that, subtract that from the carbon cost of delivering care in the community and drilling down into all that. So by subtracting the two, we could actually calculate the ultimate real net prevented carbon emission. So as you can see here, over the 1,260 patients cared for over the year, we saved approximately 6,064 bed days, and that equated to 283,337, don't forget the 7 kilograms of CO2 So that for us was actually really very meaningful indeed.
Thanks. And just in case you don't know what 283 tons of carbon looks like, it's similar to 700,000 miles being driven, which is just shy of driving to the moon and back. Or we've also done another comparison given the current political climate, which is it's the same as 656 barrels of oil consumed. So that's massive. That was just over a year's worth of patients have avoided that amount of carbon by being treated in some form or another within the virtual wards for one trust. So it's very much, something to be shouting about, we think. And in conclusion, this is the sort of final slide, we found that virtual wards are significantly lower in carbon emissions than a traditional inpatient bed day. As David said, in our case, this was 4 times lower. Other trusts within England who have higher travel days, more significant travel, have also found similar results in the sense that it's significantly lower than a traditional inpatient bed day, which is positive. This probably won't be a surprise, but our manual data analysis was more accurate than our large-scale BI data draw. We know that our healthcare systems and research tools weren't designed to consider patient carbon activity points that lends itself to evaluating the carbon impact. So that's something to consider. And finally, we were able to validate the methodology of the national toolkit. In terms of next steps, so we'd like to do more research. There's always more research to be done. Things like remote digital devices. This isn't something that was well recorded within patient notes, even in the manual data draw. And there's not enough information about the carbon impact of such devices anyway in existence. So if we're really to lean into digital models of care in a way that I think this is heading, this is a detail that must be considered in more. We identified carbon hotspots for the trust as a part of this process as well. We didn't have enough time to go into all the details of this, but it's all within the paper. We would like to sort of implement actions locally to help reduce the carbon emissions of that pathway even further. And finally, we want to and have been spreading the learning about our findings to other virtual wards networks to ensure and to help and encourage that this is considered when designing or expanding virtual wards or any other digital models of care. So thank you. And I think we're going to have questions a bit later, if I'm not mistaken.
Okay, thanks, David and Becky. Absolutely fascinating. And the impacts that you've shown are really something as a take home in terms of the impact that can be created annually from one NHS trust. And when we extrapolate to what the system as a whole can do is really something that we should be getting a move on. Also, I think, conceptually to look at virtual care from the bed days saved and also looking at blended care in terms of virtual plus inpatient in-house, the impact that it could still create is something really as a key take home for me at least. So I'll just, before we get into some bits of discussion, I have a few questions as well for my speakers. I'd like to bring in Sai, my colleague from Apollo Hospitals. Sai, we've heard from the Australian perspective, we've heard from the NHS from a health systems perspective and the NHS, the trust perspective. How do you see virtual care and what are some of the use cases that have proved very useful for you and those that can have a significant impact on sustainability and driving that really across the system?
Great. Thank you, Karan. And thank you for the co-panelists for amazing presentations. It's really heartening to note the amount of deep research that's gone into this and great work by both teams. I think one of the things we've seen in India, especially at Apollo Hospitals, and by the way, thank you, Ilona, for organizing this. This is really fabulous. What we have seen at Apollo is that virtual care is really a part of our day in the sense that it's not another piece of work that we do. So, for example, I'm sitting in my outpatient department right now. I would see patients physically, and then I would log in and see a couple of patients online, then follow up with the people I saw earlier physically, virtually later in the week, etc. So it's become part of our normal routine. And I think COVID obviously accelerated it, but Apollo has been on this journey for a long time. We also do various versions of virtual care. One of them is the direct-to-consumer version. Then we also do remote critical care, and we do that for India as well as for other countries, including to Fiji, as an example. And I personally also do remote critical care for the United States from India. I've done that for 15 years now, and many people do that. What I've realized is that about 80%, in my opinion, of things which you can do physically can be done virtually. There are some things which I believe in the very near future machines can do. But for now, most of medicine is cognitive, and that can be delivered virtually. The importance of empathy, hand-holding, eye contact cannot be understated. So that part will obviously have to be done physically in most situations. But I have been able to have very emotional conversations with patients and their relatives 8,000 miles away. So I think distance, as one of our senior colleagues used to say, geography is history. And from that standpoint, really measuring the impact of virtual care in this manner does make a big difference, because we've been looking at it from various angles: money saved, time saved, etc. But the carbon footprint change, I think, is absolutely something that we should be looking at even more deeply. We did a brief studies in our remote critical care at Apollo Hospitals. We get patients from 1,000 kilometers away who drive in because they don't have access to care locally. We actually measured a fossil fuel usage as well as transportation cost usage, and we did an abstract on that. And it was very clear, and this was about 7-8 years ago, it was very clear that there was a tangible benefit to patients. Because what happens a lot in not just India, but many countries, is if one patient comes for an appointment, he's probably bringing his wife, his brother-in-law, the kids, because they can't leave anybody behind because there's no great support structure for the rest of the family. And when all of them show up in the urban center, they're dealing with boarding, lodging, all of those extra costs. So I think that balloons up. So to me, virtual care is not just a direct consumer cost saving in carbon, but there is a secondary indirect cost saving that happens. The last point I just wanted to share is in terms of, we are using technology to a massive extent. And I'm hoping the technologists get efficient in the use of energy, especially they get smarter with the algorithms and smarter with the need for the amount of computing power that's required. And I'm thinking maybe there'll be a little bit of balance where we're using a lot of energy to do what we do today. In the future, it'll get less because of efficiency in algorithms and the elegance of the coding. But at the same time, I think we should realize that there are some simple things we can do. And a simple phone call might be sufficient. You may not need a video interface. A lot of planning in terms of caring for a patient may obviate the need for intervention where you have, say, an asthma care plan, where you tell people these are the 5 things to do before you reach out if things don't get better. This will need extra time in each visit, which most of us don't have. But I think a little bit of planning will help. And also, the final point I want to make is that I think there's a regulatory artificial walls we've built up. COVID brought them down. If you think about it, there's, yes, a deficiency of providers in one area, but there isn't in another area. But the same quality of care is being given. As long as standards of care can be met, as long as people are understanding that we will not compromise on the quality, I believe healthcare can be global. A doctor in India can help a patient in America or vice versa. And where do we see this in complete proliferation? Aviation. Pilots are flying over dozens of countries. They're talking to air traffic control. They have uniform protocols. They switch planes regularly. I think healthcare can do that. So that, I think, would be my comment I would like to close with. Thank you, Karan, and thank you, my colleagues, for wonderful points.
Thanks, Ian. And very important point in terms of, if we can assure outcomes and patient safety, then why isn't healthcare global in terms of, how we can bring that together through virtual care, and also some of the economic savings, the secondary impacts that one has beyond carbon, very important, especially for the global south. So also for those who are participating, please feel free to put questions to this wonderful set of speakers. I'm happy to get some answers from them. But I'd like to just open this up for a brief discussion. I'd like to bring in David, Kate, Becky, really into the virtual ward model. I think it's fairly complex, requires a lot of coordination. If somebody was really wanting to start this, whether they're a clinician or an operational leader, what is the segue to really get started? Any of you?
It's a virtual wards question more than a sustainability question, so I'm going to hand over to David.
So just to clarify the question, is it starting a complement of virtual wards, or is it
yes? How do we really? How do we really start?
I think I was really what was just said about virtual care. I mean it's been widely kind of joked about that the second phone call that Alexander Graham Bell made was to his doctor. So the fact is that virtual care via telephones has been around for a very long time, and Dr. Sai was just saying, that's blended into our life, and that was hastened by COVID. So I suppose the question is what kind of virtual care do you want to provide? Because to be able to, even in the NHS, we're becoming more and more aware you've got to show value. And this is the real thing, is what value is. And this is something that we've started working with 2 universities locally, because a lot of people throughout the world are working in private systems. And if you can't show value, then you're not going to be able to attract funding. So if your value is in the acute sector, which is what we were commissioned to provide, is acute care, genuinely trying to care for people who are sick at home, who would have traditionally had care necessitated in hospital. So you've got to select your cohort of patients, then you've got to gain safety, credibility, and trust. And there has to be a service that needs to be open 365 days a year for more than half of the day, because let's face it, everyone gets sick out of hours because we don't generally live to work. We tend to work to live. So the fact is that you have to have a founding service. Now, I would suggest you go for, in each of your hospitals, you will have different needs. Rachel's patients will have different needs to my needs. And also Scotland, we know, has a very different cohort of disease to the south of England. We have a lot of very old, frail people by the coast. So you could say, what is the biggest bang for your buck? And therefore, once you've got your cohorts, once you've got your vision, and once you've got what you need, start small. The problem we've seen with lots of virtual care and lots of virtual wards is people go too big too soon, collapse because they are not safe. Because if you're running an unsafe service for 20 patients and you rapidly scale up to 2,000 patients, it's still a really unsafe service, but your harm levels have gone through the roof. And also clinicians, and that's what you need. You need consultants, doctors and consultant allied healthcare professionals buy-in. If you don't have buy-in across the system because you're rogue, so you've got to have good clinical governance. And for me personally, I've got another hat working for NHS England across the south. My concern when I visit different hospitals is the lack of governance. And at the moment, virtual care, it feels like we're going through a kind of internet revolution at the moment, because we have lots of people doing different things. And I completely agree. We could coordinate and have such a safe, well-governed service throughout multiple countries. You only need to do it once, but start small, heavily governance, get buy-in from your clinicians, then expand. Don't get greedy too quickly. And we're lucky in the fact that we run now, I think it's 10 to 12 acute virtual wards. These are highly ill patients that if you take your foot off the ball, they'll be on intensive care by Monday if you haven't looked after them since Friday. So build up slowly, and certainly in different geographies. That would be what I'd say is it will come, and when clinicians trust you, your service will expand rapidly.
That's great. And I think the important point there, David, was really, how scale can sometimes become the enemy of safety. So start small, get buy-in, get governance. And Will has a question and a comment that is sort of building on that notion, and you addressed some bits of it. What are some of the barriers to rolling out this model more widely? I know you touched upon it, but any further thoughts on that, the barriers in terms of the rollout? David, yeah.
So I think Becky and I work hand in glove on a lot of these things, and so we've got system problems which are digitalization. So I'm sure Apollo hospitals use a completely different digital platform to us. Why on earth does that happen? Then if you start, and in the NHS, we've got GP surgeries that are privately funded that use another digital service. If you want to get the digital agreements across to share the data, patients, if I said to a patient, I can't access your private records, they look at you like you're crazy. Now, the fact is patients ultimately, if their data is being used for the right reason, I've come across very little resistance as long as they get good care. So I think the digitalization and sharing is really important. And the one thing for me and Becky, we've been working very much in the population health space. Now, I firmly believe that in the past, yes, a lot of funding has gone towards, surgeons. I'm guilty, people in hospitals, professors of this, siloed healthcare, people building ivory towers, and that creates siloed care. What we need to do, those silos need to be shattered, and we need to start working cooperatively together. And that does mean giving up a degree of sovereignty of your service. And that certainly for someone, who's worked in traditional hospital systems, that's very hard to swallow sometimes, because you are, and you have to learn to share and share your toys neatly and calmly in a system that is actually, well, certainly in England, our funding restrictions are massive. And I think we need to realign that. And you only need one or two people to create barriers, and then the whole system starts to fall apart. So there is, and I think somebody talked about, I think Rachel, you were talking about kind of paradigm culture shift. And I think for me, that is absolutely key to be able to do that. And that comes with time, trust, and credibility.
Thanks for that. Becky, would you like to add anything from your experience on the barriers?
No, I mean, really just highlighting what David said, but I think one of the biggest challenges that we've had is obviously there's lots of different services setting up virtual wards within Hampshire. And obviously we sit within the acute trust, but obviously there's also community services delivering virtual ward care as well. And it's about making sure that we're aligning, like David said, and making sure that we are streamlining patients across the services, that we're making sure that the appropriate service is managing the appropriate patient at the right time. That can be confusing for patients because they don't understand the difference sometimes between which virtual ward they're on. So that's a big challenge for us that we're trying to overcome at the moment, and we're having to work with our ICB colleagues to try and understand where we're commissioning services and how they all fit together. So I think that's probably one of the biggest challenges that we're seeing as well, from my perspective at the moment. But it's all coming together, and we're working really closely together, and it's we're certainly seeing streamlining of services going forward. But that's probably one of my biggest challenges, and obviously the digital platform, and all working on one platform would be a dream. So we had visibility across all services. That would make our lives so much easier.
Absolutely. Thanks for that, Becky. Rachel, I want to move on to you. You heard about the virtual wards and how we could really build virtual care models, both within the NHS and your own experience and what's been done at Apollo and in Indian healthcare more broadly. What are some of the metrics that one could look at in terms of sustainability, in terms of those impacting care, and also moving the needle on reducing carbon emissions? What would those 3 or 4 or 5 essential metrics look like?
So I think emissions is probably the number one, and the one that most businesses are interested in, because I really like what David said about, how do we get that culture shift and normalizing this type of language. I actually think so in Australia we have something that's just come in about climate related financial disclosures, where all companies have to start reporting on carbon emissions. So you have to almost find that little window of opportunity. We had it with COVID in a little way, where you can start to sort of, you've done your research, you've prepared everything, you've got it there, and you see that tiny little crack open that you can push forward to get, those shifts happening. Another one's happening for me right now. I had an email this morning about the energy crisis, and can we figure out how much petrol we could save in Australia by mandating telehealth for Medicare instead. So it's all those things that if you've got everything ready, you can go. So the metrics I would say that get the most traction from my perspective are emissions, because C-suite are saying, oh, I have to now start reporting on this. So leverage that. Water is huge, particularly from a data center perspective. I think when we're the advocates for digitizing the health sector, we must stand true to our roots of making this help, not hinder, and ensure that we're looking at the water footprint as well. I think in a lot of stuff with climate change, we do tend to focus on energy and emissions, but water is it's pouring down with rain outside, which is very strange for me because it's usually drought. But water is a big issue. So emissions, water. The thing I would say for those people who are interested in this part of the PhD work I'm looking at is donut economics, which sort of looks at social shortfalls, so social metrics as the hole in the middle, and Johan Rockström's planetary boundaries as the planetary metrics around the outside. I think there's something really beautiful to look at there in reflecting those sort of metrics and how we report things.
Sure, very useful. Kate, just want to bring you in on this conversation. So we've seen the metrics that one could look at for a hospital administrator, for managers who are trying to now build some good data sets around the measuring the impact. We heard about the emission factors, we heard about intensity factors, national frameworks that are there, but within hospitals, what are some of the sources that one could tap onto to get the type of data or metrics that Rachel just touched upon?
Yeah, I think, I sort of touched on it within the presentation, that we looked at the methodological differences of collecting that information to help us. I think, we had a really passionate team, and we worked really collaboratively, multidisciplinary across NHS England and Hampshire hospitals to achieve this big result for us. But not everyone has the capacity or the time or the resource to do that. So if we can automate things, and by that I mean we're just not picking out, when we're looking at our data centers and our big BI drawouts and the evaluations that are happening, none of it is looking at it from a carbon activity point. There are slight overlaps. There's interactions with patients and clinicians that are being collected automatically that you can draw upon, but it's just not going into anywhere near enough detail for that automated process. And really what we need to be doing is doing that triple bottom line analysis. Ultimately we've got an aging population that are more complex in care. We need to make sure that as we expand our healthcare systems to manage this, it's got to be sustainable in the holistic sense of staff, as well as sort of financial and environmental. So anything we can do to automate this process and the evaluations would be great.
That's great. Sai, I want to bring you in. So we've seen the efficacy of virtual care on its impact that it can have on creating more sustainable health systems. What would it take clinicians to sort of move more towards virtual care, or adopt and adapt towards virtual care in a bigger way?
Sure, thanks, Karan. Just two quick comments, and I'll address what you just asked me. One is, I've seen in our own hospitals, we're having more green spaces. They actually have indoor plants and gardens, etc. If there is the ability to do that, we also have vertical gardens. We don't have space. So we're actually doing those things as a kind of an offsetting, simple thing you can do, which also looks nice. The other thing, which we didn't touch on much, is that India, for example, the median age is 28, which I've mentioned in other talks before, which really means there's only 75 million people who are having Western type of risk factors, because they're above 60 years of age. There's only 75 million. So it's 1 billion people in India, and then another 1 billion in Africa getting old the next 30 years. We're going to need all of this care. So hopefully there'll be better drugs which will prevent a lot of chronic disease, which needs virtual ward type of care. But I think the other side of this is also to realize that there's the things you can build in your own existing ecosystems. For example, we have a program where we do remote monitoring of patients who are in wards inside the hospital. So not in the ICU, but outside the ICU, and not just traditional telemetry, but beyond that. And what that's done for us is it's prevented complications, because in the last 18 months or so, we've seen about 250,000 patients, about 600,000 patient days. And our cardiac arrest rates came to 0 in some of these centers using simple variables. And the reason that happened is we're detecting deterioration early. So you're kind of decreasing the burden of care for many patients, avoiding the high intensity stuff by catching things early. And this, I think, is a simple way to initiate a preventive process where you don't escalate care if it's not needed. The other bit I think I would comment on is, for clinicians to start doing this, it may need a merger of home care with devices. Say you have somebody with congestive heart failure, get them a Bluetooth-enabled weighing scale, or a simple weighing scale where they make a note and then send a message, or someone checks in on them. A simple thing like that can prevent a need for more services. And if you're able to manage several of these high-impact diseases with simple innovations like this, you will avoid unnecessary transit of nurses going in and checking, etc. So you can avoid a lot of these things. And I think this is the right time that countries like India and Africa, the continent of Africa, should kind of pitch into these spaces, because otherwise you're not going to, like you said, there's 1 million beds needed. You won't have enough people to take care. I will again go back to the global nature of healthcare. If we can actually initiate programs, say between India and Australia, or India and the UK, it'll be interesting. And by the way, Apollo does send providers to the UK. We have some programs where we're collaborating. we're able to do this, but at a small scale, not at the kind of scale where we make a giant impact. I think also there is hope because the younger generation, the folks who are 15 to 25, 30 years of age, they are much more aware of this and they make very conscious choices in healthcare. They make conscious choices in everything that they do. So I think there will be a positive push because the next gen is going to want, because they're seeing the images, the polar bear stranded on melting ice, and that's what they grew up with. So they are, I think, they will be much more cognizant of the need to have a robust sustainability initiative.
Thanks for that. I do have a few questions that I'd like to send the way to the speakers. One, would you have any examples of patient care pathways? I think this was well covered in both presentations. So yes, it is effective. It is at scale, and you can really measure the impact both on the carbon side and on the patient effectiveness side as well. Huma has an interesting question on, could you shed some light on the governance and policy frameworks needed to embed virtual care as a climate smart strategy? So, David, I'd just like your thoughts on that. The NHS has a fairly robust sort of legal framework and has the roadmap for the NHS itself, and very, very good sort of governance platforms to look at virtual care and the impact on sustainability through the Greener NHS program. So what are some of the learnings that other health systems could learn from the NHS?
That's a great question. So you're right. The NHS has really lent into the idea of virtual wards, and it's published lots of free documentations which are widely available. And it's NHS. I'm not being sponsored or paid for by the NHS, by the way, but it's lots of ideas of what its visions are and how to do it. And within that, there's different guides about what one would expect if what the government and what clinicians expect the level of care, the bare minimum level of care to be for and this is very much based on acutes. Becky and I also led two of the NICE, so that's the National Institute for Clinical Excellence, so papers on virtual wards safety. And shamefully, within that panel of the great and the good, carbon didn't come up in that. I think we completely and utterly missed an opportunity. Admittedly, that was 4 years ago, but that's and that's something I'll openly have my head up and say that's shameful. But I think certainly there's a lot of good quality NICE guidance out there, and then we're very much held to account by our CQC, so these internal inspectors that turn up. I'm sure many of you have worked in the UK at different points. Everyone lives in fear of these people turning up and closing down your hospitals, and I'm sure other healthcare systems have that. Although I've never worked in America, but I understand different parts of America are actually very much licensed to do and deliver care differently. But certainly, I would certainly encourage you to borrow the already strict guidance that's already been laid down and quality tested. And then I'd say the one thing for me, which is really cool, which Dr. Sai, you talked about, is the proactive case management. This is the future. If you can tell me I'm going to get diabetes in the next 10 years, or I'm going to have a silent MI, then what can you do now to change my outcome so I live a better life, so I create less impact on the healthcare system going forward? We have good data now from one of my colleagues, who I'm happy to introduce you to another time, has been working with a frail population towards London, and can actually now anticipate through simple remote monitoring, because these are frail people, they can't use clever whizzy gadgets, of what puts them into the red zone of either being high likelihood of falling within the next 4 months. We have predictive indicators. We can actively now, through minor interventions, telephone calls, awareness, change the outlook of healthcare. Now, if we are going, the huge level of benefit that would have in India and Africa, if you could risk stratify your population, very simply, would be massive. Now, all of that is being written in real time right now, and we're starting to roll things out throughout the south of England. I'm sure there's very similar things going on in Scotland. I'm not privy to what's going on in NHS Scotland, but this is where the good stuff is, and this is all being very heavily governance now, and all of that is going to be is readily available for publication through the NHS website. So I can commend that to you.
Great. Thanks for that. Rachel, there's a question from Shweta who's brought up the impact of virtual care on building a resilient health system and a resilient model. And we know Australia has geographic disparities and access issues because of that. So how do you really see virtual care as something that drives resiliency within the health system as well?
Yeah, great question. Thank you for that. So, I mean, we have had the summer of fires, floods, storms, bushfires, and everything, and it seems to, I'm sure all of you are facing this, that it's becoming normal. The once in 50 years is now once every year, once every couple of years. And so for us, it's really about building the infrastructure to allow for fluidity between in-person and virtual. And so COVID kind of forced the hand of making us go virtual in a lot of places. And technology is never often, it's not often the problem. It's often more the funding model and the culture and barriers of that variety. And I think we've overcome a bit of them in terms of the adoption of virtual because of COVID, which is great. But I think it's about continuing it to be there. There was a lot of people who, after COVID, said, "Oh, we'll just switch off the Medicare funding for telehealth. We don't need it. Everyone can go back in person." But we sort of showed that there was a lot more benefits than just, stopping people maybe picking up a virus in an in-person centre. So I think that the key is there's not one answer, right? It's a million little mosquitoes in the room doing local projects that are doing stuff. It's people sitting in the pharmaceutical boards meetings and in with policymakers, continuing to push the message. It requires all of it to happen. I wish there was one simple answer to say, just say this and ta-da, it happens. It's unfortunately not that simple. Making sure the infrastructure is there and absolutely making sure the funding models are there behind it to support it. Otherwise, it goes nowhere.
Couldn't agree more. I know we're at the end of our time, but there is this very important question that Grace has put on the chat box. And Becky, if you could take this, how do we make sure that we continue to maintain interpersonal engagement between healthcare professionals and patients while we move to virtual care? How do we make sure that, that doesn't fall through the cracks?
I jump in just on this one quickly?
Yeah, go for it.
Yes, go ahead.
I just read a study literally last week that showed that 70% of young people in the US prefer to have a chat with an AI bot than a human, which concerns me greatly. So I think the thing is that there are some people who prefer some types of conversations virtually and some in person, and it's about enabling that fluidity of people to move between the two, and as the team from the NHS very rightly pointed out, that the systems in the background allow you to access the patient data regardless of which way you're delivering that service. But giving people options and choice in how they allow for those conversations. And there will be people that prefer virtual and others who prefer in person. How do you support them to enable that? Or how do you teach your clinical teams certain behavioral nudges or tools or tone of voice, or even color therapy, the colors that you put in the background of your consultation while you're having a virtual call can actually influence the call too. So bring all of that to the picture, and I think you'll get there.
Becky, any thoughts on that?
Yeah, no, I think It's a really good question. I think obviously continued engagement with all of our clinicians, patients, and relatives is really important. And we've reviewed a lot of data recently, and the results were really positive. Patients enjoyed virtual care, but engagement is really, really important. And we have to get a better understanding for clinicians and for the public on the benefits of virtual care. I still don't think the message is as strong as it could be, and that's even some of our colleagues internally within the hospital. It's still allowing them to have an understanding of the benefits of people being cared for at home versus being in hospital. It's a huge piece of work that is bigger than just our hospital. We almost need governance support as well, so the public have a good understanding of the benefits of being cared for at home versus being in hospital. But yeah, that's probably the key for me.
Okay, thanks. And we're out of time, but there is one last question. I'll just go around to all our speakers. So please, be fairly quick on this one. I know we all hate rapid fire questions, but this question is quite interesting in terms of the opportunity and how do we promote virtual care. What is it that in one sentence we need to do over the next 5 to 10 years to really help reach virtual care to its own potential? So Sai, what is it that one or two things that we need to do to promote virtual care?
I'll have whoever's listening remember two numbers. The one is 4.5. That is 4.5 billion humans do not have access to essential health services. Virtual care can solve that. The other number is 1. Whatever we do needs to matter to the one person you're treating in front of you. Because it doesn't matter what we have theorizing, that one person needs to benefit.
Kate?
I'm not going to stray too far from that point, to be honest. I think that CO2e doesn't mean anything to hardly anyone. I work in sustainability and I can only just grasp what CO2e even stands for. It's about patients. If they are benefiting from a virtual ward care, then that has to be the most important thing.
David?
So for me, I think it's getting the right person at the right place at the right time. So I think care is care. We're 77 years in the NHS and we're still not doing it right. I think military hospitals are around a lot longer. So virtual care will just become care. And it's all about focusing on that patient.
Becky?
Yeah, really the same as David, to be honest. So I think it's about what's best for that patient. And if we can deliver the same hospital level care at home, we absolutely should be considering that. And it's getting the confidence and buy-in from clinicians to be able to deliver that. But it's about the patient. Everyone would rather be at home, wouldn't they, than be in a hospital bed. Why aren't we? This is the future, and this is what we should be aiming for.
Rachel, last word.
I'm going to be controversial. Yes, it is about the patient, but it's actually about the business model and framing how you put this forward to decision makers in the language of a board and investors. Use the models that will show them you have to do this. It's going to affect climate change, all these. Use the numbers that get them to say, absolutely, yep, that's what we need to do.
Thank you. And thank you once again to this wonderful set of speakers, David, Kate, Becky, Rachel, and Sai for taking time out and really enlightening us on the impact that virtual care can help create to build sustainable health systems and models. And with that, I will hand it over to Sai for his closing remarks before we hear from Ilona to round this up. Thank you.
Thank you, Karan. Amazing, beautifully conducted. And I think we have had a lot of interaction. Looks like it's a hot button topic for everyone. So I think it's a great choice, Ilona, for suggesting this and building through the last several months, getting this going. I think we're out of time, really, so I will be very brief. I think virtual care is something that we are passionate about at Apollo Hospitals, and the IHF is really trying to get this out to the world. We do have periodic webinars on various themes. The conference in October at Seoul, we're hoping that we'll have a lot more engagement. And I truly like what David said and truly believe that it's ultimately it's care. It doesn't matter how we do it. I mean, we do our banking without thinking. We're not going to a bank anymore. So I think healthcare is also can be done that way for the vast majority. this is not to say that we don't need compassion, that we don't need kindness, we don't need the empathy. Those are critical. That's what makes us human and healthcare the way it is. A lot of healing comes from that aspect of care. But I also like what Rachel said about the business model aspect, because you do need this to be sustainable. And every health system is having challenges in that angle. I believe that if we put the sustainability lens as not as an afterthought, but as a design principle from the beginning, and virtual care, for example, becomes a part of your structure, that's your normal business as usual and not an esoteric something you're going to be doing, that I think will create the change. And partners from the NHS in Australia, we're happy to collaborate. There's something we can do together. Would love to do that. If the route to that goes through Geneva, so be it. Ilona, happy that you brought it all together.
Thank you, Dr. Sai, and thank you, wonderful presenters. And Dr. Karan, your chairing is just excellent as ever. Thank you for driving that conversation. Please all look out for the IHF newsletter, because we always have something about virtual care. It's out at the end of every month. You can sign up through our webpage, and you'll also find out about webinars there. And finally, just a note that the Special Interest Group is a platform for all of the IHF members to share and learn from each other about virtual care. So please, if you have any ideas or thoughts or suggestions on how you can be involved and more involved in the work that Dr. Sai and I are doing on this SIG, then please just get in touch with me by direct email. Thank you. That's it. Enjoy your days, evenings, afternoons, everybody. Thank you all. Bye-bye.